Hello, everyone, and welcome to another therapist training video. Today, we're talking about a therapist's duty to warn and protect. More specifically, we're going to be reviewing an article called the Tarasoff Two-Step, written by former California Association of Marriage and Family Therapists, camped attorney David Jensen. Without much ado, let's head towards the presentation. What I'm hoping we're going to get to do today is talk through this article so that you can understand the nuances of this article and what David Jensen Esquire wants us to know and understand about this role that the therapists have to warn and protect. The big picture idea here is that the law provides therapists with this umbrella of confidentiality and privacy, where things that are said between client and therapist are kept private, upon the foundation that if the therapist learns of any danger to their client or to the outside world, that the therapist is obliged to break confidence and protect people for the greater good. It's my job to protect someone who's actively suicidal. It's my job to warn authorities and potential victims if my client is going to go hurt someone. And we're going to use this article to understand the nuances of that approach. For me, the thing that I like about this article is that I find David Jensen to be very well informed, very articulate, and very creative in the way that he expresses his explanations to us. And so, at the risk of being a little boring, what I literally want to do is to walk through this article and highlight the pieces that I think are most important of this foundational article for marriage and family therapists in 2024. So the original article written in 2012 and then updated a handful of years ago by Michael Griffin. From the beginning, Jensen uses the idea about a dance. And when it comes to dancing, there are prescribed steps and moves, and that everyone knows what those steps are, and it's in the grace and artistry at which we perform them that our skillfulness is conveyed, and artistry, I suppose. The same holds true with this idea that for therapists, we are asked to, when we're receiving confidential information, to assess for how dangerous other people may be in, or our clients. And then the second step of discharging, doing something about it. And so what we're going to do is walk through how this came to be known. Jensen suggests that the more care and effort we can put into preparing for this responsibility, the better off we will be when it comes to actually acting upon what needs to happen. And as only Mr. Jensen will do, he says it's not as energetic as the twist, not as sexy as the tango, nor as elegant as the waltz, but absolutely necessary for therapists to know how to do and to do so well. The other piece here is that he's going to talk about California Welfare and Institutions Code. He's going to talk about court rulings and things like that. The part that I want my students to be aware of is that all of these messages come under the same bucket of being from the judiciary and the legislature, I suppose. But these are the obligations that therapists have. And knowing about them is going to be more important than other pieces about where the law actually came from itself. There is another article about duty to report that we may glance at the end, but I want to focus on this part. And so David Jensen goes into detail describing about what this Tarasoff case means. Tarasoff is a name that's now nationally linked to this idea about how a therapist is responsible for protecting intended victims from harm if the patient says that they're going to hurt this person. It's a person's last name, and it's something that applies only to the state of California. It turns out every other state in the union have their own specific laws and regulations when it comes to understanding how those states are going to enforce this idea about protecting the public good. But for us in California, the idea is that the Tarasoff case started in 1968 at the University of California, Berkeley. There were two students we're going to be talking about. The first was Prosenjit Podar, an Indian graduate student living in an international house there in Berkeley. And he met Miss Tatiana Tarasoff while attending folk dancing classes. And as will happen with dancers, young and old, Podar became infatuated with Tatiana. And they saw each other, every week while they're at school, most likely through this dance class and other ways, but they saw each other on a regular basis. She ends up kissing him on New Year's Eve in 1968, which to Mr. Podar really indicated the depth of their interest and commitment to each other. And for him, it was a really big changing point that allowed him to become quite infatuated and unhealthily connected to his idea about being attached to her. Alas, she did not reciprocate these feelings, and Mr. Podar took this internally and became very depressed. He neglected his appearance, his studies, and his health. He had a difficult time functioning, and even at that point had daydreams about killing her by blowing up her room. So it struck him in this horrible way. Poor fellow, trying to figure out what to do, has a really difficult time, and all of these things come bubbling up. A friend suggests he finds counseling resources, and he does so on campus. And in 1969, he starts working with a psychologist named Dr. Lawrence Moore. It became clear to Moore that Podar was someone who was in a very difficult position, someone who was diagnosable as having not just depression, but such intrusive thoughts that it was likely that he was not able to make good decisions about how he was going to behave and deal with these difficult emotions he had internally. The clinician did a great job of informing the university police and talking with his client about how these things are not supposed to happen. But one thing that was missing was no one broke confidence to warn Tatiana Tarasoff. As we move through this yellow paragraph, what I've looked to do is to use the blue to kind of indicate main ideas as we go through. Yellow is really key components, and then an off yellow to highlight things that we might want to nearly write down verbatim to really understand what the significant pieces are. And so Dr. Moore is really worried about Tatiana. He probably knows she's coming back. He's diagnosed Podar with paranoid schizophrenic reaction, acute and severe. So saying that there is such a disturbance in his mind that his connection with reality and his ability to make good decisions is no longer present. And so Moore initiates a 72-hour hold for the safety of the client. That is, that at hospitals in the United States, if someone is not of their right mind, it's possible for them to get up to 72 hours where they're held against their wishes. And hopefully over 72 hours, 3 days, medical staff is going to help someone become more calm and of their right mind and thinking and ability to handle the difficulties that come with being a human being. Alas, that wasn't sufficient. And so as we see here in yellow, and so as Moore contacts the police and through a letter, so verbally and in writing, he's going out of his way to really communicate that this is a dangerous situation and to even be wary that Podar would seem very rational. And yet when the campus police interviewed him, they were satisfied he was not dangerous to Tatiana. That ended up being a big mistake. They just asked him to stay away from her, and that the campus police allowed Podar to go free. We can see here the difficulty of being in this situation as a clinician and as a client, but in this case as a clinician, that even when we do what looks to us to be the right things and we're partnering with other people, there are many ways that things can go awry in really difficult situations like this. And so I can feel for the families of all these folks, the clinician trying to do his best, the client not able to find another way to deal with his upset. And so when Tatiana Tarasoff returned to the university in the fall, he started to follow her, and he became very upset, understanding that she wasn't interested in him romantically. October 27th in 1969, he rather brutally killed Tatiana Tarasoff. despite all of the warnings and good intentions, that did not go well. He even called the police afterwards, kind of knowing that he had done wrong and needed to go to jail. And so afterwards, Tatiana Tarasoff's parents sued the University of California, the campus police, the hospital, seeking damages for the wrongful death of Tatiana Tarasoff. They essentially had two theories. Someone should have warned Tatiana that Podar intended to kill her, and that the parties failed to keep Podar under their medical care in a way that would have prevented him from causing her such great harm. In 1976, the ruling came down that has changed the course of, or defined the course of legal and ethical actions for psychotherapists in California and across the country. And I'll take the time to read through these two paragraphs here. When a therapist determines, pursuant to the standards or the profession should determine, that their patient presents a serious danger of violence to someone else, the therapist incurs an obligation to use reasonable care to protect the intended victims against such danger. The discharge of this duty may require the therapist to take one or more of various steps, depending on the nature of the case. Thus, it may call for the clinician to warn the intended victim or others likely to apprise the victim of the danger. That's number one. Two, to notify the police or the authorities. And three, take whatever steps are necessary under the circumstances. And so very clearly articulating this idea about warning the victim, informing the police, and doing anything you can to prevent someone from causing harm to one another. That third category is going to include things like hospitalizing someone. I suppose in some instances that might be about removing a gun from someone's possession, right? But there are ways that the therapist could take action to reduce the way that someone else could be hurt. This continues in the second paragraph. This duty to protect can be compartmentalized in two steps. The first is an assessment step, which is what we're talking about, to reasonably determine if the patient is dangerous to another person. And then number two, if the duty to protect has been triggered, it leads to the discharge step. And that to avoid liability for the violent actions of their patients, therapists must understand and be able to do both of these steps well. And here's this two-step dance move that Jensen suggests to us. This idea that first and foremost is a whole lot of assessing in many different ways, and then discharging, knowing what to do in certain circumstances. And so the good news is, from this horrible situation with these young people, there's clarity in our profession about what needs to happen. The idea is that when working with clients, the therapist has an obligation to be assessing for dangerousness over time as things continue. I'm thinking about the idea about multicultural competencies and about working with minors and the ways that there's just a lot of gray area in how this can be, what this might look like in real life. Does a little child really mean it when he says he's going to shoot the other kid in his class, right? There are times when that answer is very much yes. And I can imagine circumstances when that might not be the case, when it's a little child who doesn't know what they're saying and doing. Part of the assessment process is not knowing the future, not divining what's going to happen, but rather using all of our skills and competencies to make a good decision about what's likely to happen. And if there is a risk, to then discharge action to do something about it. In the law, there's this idea about grave bodily harm that's quite literally defined about what it means to hurt someone else. And in this paragraph, it lists some of those pieces. But the idea is, if I threaten to scratch the paint on someone's car or scratch someone, neither of those are going to be grave bodily harm. Grave bodily harm includes something quite serious and likely violent. That is the legal standard that a therapist has to keep in mind when it comes to understanding what's allowed for breaking confidentiality. And of course, death would be worse than grave bodily harm, and that would be something that needs to be reported as well. Okay, more from the Supreme Court of California on Tarasoff. We realize that the open and confidential character of the psychotherapeutic dialogue encourages patients to express threats of violence, few of which are ever executed. Certainly, a therapist should not be routinely encouraged to reveal such threats. Such disclosures could seriously disrupt the patient's relationship with the therapist and with the people who are being threatened. To the contrary, the therapist's obligation to their patient require that the therapist not disclose the confidence unless such a disclosure is necessary to avert danger to others. And even then, that the therapist reveal that information discreetly and in a manner that would preserve the privacy of the patient to the fullest extent compatible with the prevention of the threatened danger. So what that part means is it's not okay to get a billboard or a television commercial or announce on Instapost that this particular person is a danger to this particular person for this particular reason. But rather, the therapist should look to discreetly warn those involved. These are the families and people who I think need to know about this, not everyone else in the state, right? But this idea that to reveal this information, super rare. It's just we need to know the procedures in place if we were ever to run into this situation. Here, I like this idea about how therapists are not expected to, with 100% accuracy, predict the future or future violent events in particular. What we're asked to do is use reasonable judgment to make a good assessment. The standard of care is, what would most therapists do in this kind of a situation most likely? What are the kind of things that a competent person would do? Clinicians need to demonstrate that in their work and in their notes, that they've done the best that they could. Again, words from the California Supreme Court. We recognize the difficulty that a therapist encounters in attempting to forecast whether a patient presents a serious danger of violence. Obviously, we do not require the therapist in making that determination to render a perfect performance. The therapist need only exercise a reasonable degree of skill, knowledge, and care ordinarily possessed and exercised by members of that specialty under similar circumstances. And so here's this idea that there's a standard of care, and that if I am familiar with the laws and regulations, and I am doing what most people in my situation would do, that's probably sufficient enough. And for me, I am not an expert in diagnosing severe psychological disorders that might lead people to act inappropriately. I have training in this work as a normal therapist would do. And that's what we need to do as average normal therapist, to understand these rules and regulations and figure out what a reasonable practice would be to do. And this phrase, applying education, training, and experience to the facts of the patient situation, that part's important, that you need to demonstrate that you're relying upon your education, training, and experience when you're making important clinical decisions. It's not discussed here so much, but the idea about consultation with others and talking with people can be really helpful, as well as continuing education through modalities like this. And so the clinician is doing their best to assess what's happened and to make a pretty good idea about whether or not someone needs to be warned or not. I'm reminded of the idea in child abuse that it's not the clinician's responsibility to investigate whether or not child abuse has happened, but if there's a suspicion that this is a possibility, the clinician should suggest, if the therapist has a suspicion that child abuse is occurring, that needs to be reported. To me, it falls under a similar kind of category here, that I can't know with certainty what's going to happen, but if I have suspicion and concern, that's when that individual judgment needs to be evaluated and trusted and bring in appropriate support. Mr. Jensen goes through here this process talking about three different factors that were important in Podar's case with Ms. Tarasoff. I'm going to skip forward to the next one that says that another critical issue for consideration during the assessment phase is the patient's history of committing acts of violence. It turns out that an adult who has a history of acting violently in the past is more likely than other people to commit acts of violence in the future. And so part of the assessment process for therapists needs to be asking, have you had a history of violence in the past? How have you responded to difficult situations previously? That's an important part of assessment for us. Jensen brings up the Jablonski case here. Additionally, the idea is that, as per the section in yellow, and so Mr. Jablonski had murdered his girlfriend, Melinda Kimball. The District Court of the United States explained that, unlike the killer in Tarasoff, Jablonski made no specific threats concerning any specific individuals. So he didn't say, I'm going to hurt this person on this day. There was nothing like that. Nevertheless, Jablonski's previous history indicated that he would likely direct his violence against Kimball. He raped and committed other acts of violence against his previous wife. His psychological profile indicated that violence was likely to be directed against women very close to him. And so this case ends up being one that we need to know about because it explains to us here in California, accepted practice, that what we need to do is understand if there is a history of violence, that's something that is worth us taking into consideration when it comes to reporting. In blue, a report from Dr. Simon, every study on the assessment of violence risk factors has found that the single factor most highly correlated with the potential for future violence is a history of violence. So there's that part, the importance of assessing. And then we'll get in a moment to the idea about whether or not threats have been made specifically. All right. So the first part here, to assess all that we can, and then to discharge the duty protect if we think that something is wrong. If after the assessment phase, the therapist thinks that the patient is probably not likely to commit violence, that doesn't mean that our job is finished. It means that we need to keep assessing over time and keep determining whether breaking confidentiality is important to protect the public good. Recent additions to this understanding of the practice is the part that I'll read this piece here about what we hear from other people. In assessing for violence against others, the threat to commit violence can be relayed to the therapist by a family member of the patient, and then the therapist must assess the patient's capacity for violence in light of that relayed information. The therapist does not have to hear the threat directly from the patient. So this is really important. It's one thing for my patient to say, I intend to do harm to this person. But what the law says is, if I hear something from someone else, a family member, a parent, a sibling, a child contacts me, leaves me a message and says, I need you to know that this person is I know that you're this person's therapist and this person is taking acts that look like that might lead to them doing something horrible. That legally is information that must be taken into consideration. The question here is, why does the law say just family? What if it's a roommate or a partner or a boss or a best friend who's not necessarily a blood relative? The idea is that if a therapist were to hear information like that from any of those people, it would likely be something that needs to be considered as part of being factual information for the assessment process. Side note, the second sentence here, for the therapist to discharge following the Tarasoff protocols, the therapist patient must be the one believed to be reasonably likely to commit acts of violence, not someone else. So I can only report my client to the police. What that means is if my client tells me that he knows of a guy online in the next town over who's going to do an act of violence, that Tarasoff does not protect me from reporting on what that third party may or may not be doing. It could be that would result in some kind of report of child abuse, elder abuse, dependent adult abuse, depending on the facts. But the idea is that it needs to be my patient for me to be acting under Tarasoff. It could be there would be things I would do as a citizen in some circumstances, but the idea is this is about my therapist relationship with my patient. If my patient is being threatened by someone else, we should act on finding a safety plan for them in the similar manner that if my patient were having suicidal thoughts, it'd be my responsibility to be finding ways to keep them as safe as can be. So let's finish up here, moving through the duty to discharge in the Tarasoff case. There are various steps and consequences that we might run into. And Dr. Simon, again, lists 3 different categories of situations that we're likely to run into. A low risk could mean that there's not a need for the therapist to do anything excessive. There's no need to warn anyone or call the authorities, but it's a reason to keep assessing and having a dialogue, ideally with the patient, about what's going on. Moderate risk is when Tarasoff gets triggered, where the therapist says, we need to make sure everyone is safe here. Let's talk to these people about these difficult feelings and thoughts you're having. Let's see if we can get you into a hospital so you can get good care. Warning the police. That's when the clinician really takes action. The third level would include hospitalization and suing someone who's really in great distress, but following the moderate risk scenario. I'll say one thing about hospitalization, and that is that most MFTs are not in a position to order someone and require them to be to stay in a hospital. That happens when an MFT is working for a healthcare organization or an emergency room. An MFT might be trained to make that assessment and write what are called holds, or 5150, 5150 mandatory holds could be written by an MFT. If something were to happen in private practice, I think the most common 2 choices would be for the therapist to call the police and ask the police to come to the therapy office to evaluate and take someone to the hospital, or more likely that the patient would have a family member or friend, someone who could take them to the hospital, and the client might be able to check themselves in. Sometimes people are so distressed and aware of it that they're willing to go to get care that way. I mentioned before briefly that there's an idea about the statute and then the case law. And for my sake of explaining these topics, I'm going to just think of them as being both the same piece, but in reality, they're a little bit different. And so Jensen here is going to talk us through the differences between the 2 pieces. So the statute gives MFTs, and I say MFT, but this would be anyone who is a mental health care provider who's a mandated reporter, who's providing psychotherapy services, rather. Anyone who's in this position where they're hearing confidential information and treating someone. So not just MFTs. But this statute gives psychotherapists immunity from liability for the violence wrought by their patients when the patients make actual threats of violence against reasonably identifiable victims, and such therapists make reasonable efforts to communicate such threats to the victim or victims and the law enforcement agency. And so it talks about the idea about reasonably identifiable victims. This person said that they are going to do harm to their spouse, to their partner. Reasonably identifiable victim. This is different than someone saying, I am going to go hurt with grave bodily harm and cause grave bodily injury to people who happen to be at this place at this time. There's not a specific victim there. I don't know the name of the person. This person might not even know the name of the person they're looking to hurt. That would be the idea about having a non-identifiable victim. So going back to Jensen here, the part in dark yellow and bright yellow says that an MFT cannot be held financially responsible if they've acted in a reasonable manner. Now here in the off yellow, does it sound like the case and the statute are playing the same tune or different tunes for our dance? There are 3 significant differences between the case and the statute. And I think this is above and beyond what's necessary to learn again, but I'll explain to you here. So the difference between the case and the statute is how the duty to protect is triggered. So under the case, the therapist determines that a patient presents a serious danger of violence to another person. But under the statute, the duty to protect is triggered when the patient communicates to the therapist a serious threat of physical violence. So the first one, the therapist is assessing. The second one, the statute, the patient's communicating an actual threat of violence. So in Jablonski, the case where this man caused grave bodily harm, even though there wasn't a direct threat, the history of violence and the instability between the couple was enough for the therapist to say, hey, we need to step in here and do something to keep people safe. The second difference in the case and the statute are the categories of people. So intended victims. So like I said, if someone says that they're going to go cause great harm to random people, I can't identify who the random people, who the victims will be. So then what I'm supposed to do? So for example, Jensen says, if a client says, tonight people are going to die, it's the therapist's obligation to find out more information about what's happening. And then, in dark yellow, if the therapist reasonably believes that their patient would go out and commit harm to a lot of people, the therapist has the duty to protect under the Tarasoff case because the intended victims can be foreseeable victims. Although who those people are, you can't specifically say. However, you would not technically have immunity provided by the statute because you don't know who the intended victim, identifiable victims are, right? So Jensen's saying technically there's this piece missing about a therapist being protected, but therapists who are called to do well and protect the public good, if there is threat of a large number of random people being hurt, it's our obligation to warn and to be involved. And so in that particular example, Jensen says it would be appropriate to call the police and inform them of the intent so that the patient could be taken into custody as soon as possible. And that's it, right? The therapist can know these things, but it'll be the police who would be enforcing things. The third difference here is the options available to discharge the duty to protect. And what this means is that there are 3 under the case and 2 under the statute. So the 3 under the case are tell the victim, tell the police, and take any other reasonable steps. So like getting the person hospitalized. The case law says that those are what clinicians are supposed to do. Under the statute, we have protect the person and then communicate that to the law enforcement agency. So what that means is it left out the part about the therapist getting involved to get the person hospitalized or make sure they didn't have a gun. For the last time in my mind, that's nitpicky to past what's useful, but the idea is that there are very particular laws, and it makes sense to talk to a camp lawyer and consult to figure out what a clinician is supposed to do in a difficult situation like this. He makes reference to the standard of care, this idea that a reasonable person with this much information would probably make this reasonable conclusion. And as long as you can demonstrate that you've done that, that's probably what's necessary. I hate to think about clinicians being in this position. The idea about having the guilt and worry and responsibility about finding this out being a possibility would be a lot to live with, a lot to have to carry. And so this idea about finding ways to be connected with other clinicians so that we're not doing this on our own. At any rate, the case permits things like hospitalization and the statute doesn't, but that will probably be fixed, and you're better off helping someone get hospitalized than ignoring it. But here are the principles that he suggests we keep in mind. So the first part, if a patient tells us therapists that they're going to do something to hurt someone, and we're likely to do it, it's a good idea for the therapist to communicate the threat to the victims and to law enforcement. So to the victims and to law enforcement, the therapist is going to do their best to warn. If you think that your person is likely to hurt other people and there's a way to protect them by hospitalizing the patient, that would also be a good idea. Again, making that happen as an MFT without a large organization behind you can be difficult. And if the client does not communicate a serious threat, but I think after my assessment that that's likely, that's going to be following Jablonski, the therapist should discharge the duty to protect and warn. And so what we hear here is that Tarasoff comes down to two responsibilities. Do your best to assess for violence, and if the assessment reveals the likelihood of violence, then you discharge the duty to protect. As we've seen, there are a million different nuances, both in what that assessment looks like, and there are a lot of options for how to discharge appropriately. But that is the way that this case law is set up to help therapists protect their clients and the common good. Questions we'd be asking include, was there a specific threat of violence made? If I break confidentiality, am I immune from lawsuit because I'm doing the common, looking to protect the common good? Anytime it'd be possible to get someone into the hospital, I think that would be a really good option if their person can get themselves there. And again, this question about, are there intended victims or not? Can I deduce, or am I told who the person is, or do I just kind of wonder about what the possibilities are? The bad news is that this is a little complex. The good news is that the system is set up for a therapist to do their best to assess what's happening and look to take steps to protect people from harm. It's unfortunate that so many people have been hurt and lost and injured in various ways. And alas, the idea about people harming one another is something that is not going away. We still see that happening in the world around us. The second article that made reference to, and the other one is titled, Your Duty to Report Serious Threats of Violence. This, like the Tarasoff two-step, can be found with using a simple Google search. It shows up on the CAMPT website. Jensen talks here about duty to report. And the thing that strikes me about this article is the way that in the duty to report, they focus on the idea about weapons and reporting and how to keep people safe. My sense is that most of this has to do with the idea about there being a specific threat and weapon and police choices about how to move through that. I'll just read this one section here. If the patient is subject to this section of the law, the patient communicates to the therapist the serious threat of physical violence against a reasonably identifiable victim. There's the threat. We'll consider the issue of what makes a threat different from a threat in the next section. A threat made by a patient then prohibits the patient from possessing, controlling, purchasing, or receiving, or attempting to purchase or receive weapons for 5 years. The 5-year time frame begins when the therapist fulfills the duty to report law with law enforcement. So what this says is that there are ways in California where if a therapist says, I think this person is a significant threat to someone else in particular, that there's a system in place that would keep that person from having access to weapons for 5 years, not able to possess or receive, handle weapons. And what that means is that we should know that there's a good system in place to make that happen. And it means that their client is probably not going to be very pleased to have this taken away. So particularly if the client is someone who's a gun owner and who wants to have access to their possessions, we can imagine they would be really upset about this. Jensen gives the example about, and who do you warn? How do you figure out which person and which police body to warn if the client who's made the threat and the identifiable victim and the place where he's going to do it are 3 different jurisdictions? How do you figure out how to do that? At any rate, I think that that's the the part that's most helpful from that article, but you can read that one also if you'd like. Closing words would be, it's unfortunate that the human condition is such that we are sometimes in a spot where we feel like there's no other option except to harm other people. And the good thing about therapy and therapists and medication and treatment is that there can be a lot of good done to keep people from ending up in a position where they threaten others. But when they do, there are particular steps a therapist needs to take. And I hope that this video here will help explain a little bit more about what some of those are. Wish you good luck in your studies and hope to see you next time. Bye for now.